So everybody knows me for my pediatric airway discussions. So I thought I'd also let you know that I actually have an interest in managing adults with upper airway obstruction and obstructive sleep apnea. And wanted to give some paradigm proposals to help people understand the topic. So, whilst the condition is called obstructive sleep apnea, the reality is, particularly in adults, is that we actually have obstruction, and by that what I mean is fixed points of anatomical narrowing, and then we also have collapse, which is parts of the airway falling in on themselves. So, if we look at obstruction first, the sequence is quite simple in terms of thinking it through anatomically. You can have a blockage with breathing through the nose, and that can be because of something in the nasal passages, or there's a space behind the nose called the postnasal space, and that can be a problem. Or we can have a problem through the throat, so that can be starting with, say, for example, a big tongue. It could be big tonsils. It could be the soft palate is floppy and flapping around. And then moving down into the lower part of the throat, it could be the lower part of the tongue. On the back of the tongue, there are also tonsils. Or it could be a problem around the voice box. And on top of all of those options, we always need to be mindful of the possibility of a cancer or a tumour causing airway obstruction as well. So they're anatomical obstructive points. And then we can have collapse. And the things that can collapse, the outside of the nose can collapse inwards. So we call that part of the nose the nasal valve. We can have the lower part of the throat collapsing in on itself. So the lower part of the throat, we call that pharyngeal collapse. We've got nasal collapse and pharyngeal collapse. And then around the voice box, we have this thing called the epiglottis, and that can collapse too. And the reason that differentiating these things is important is because that then determines what treatments and managements are appropriate. So, for example, it's often said that CPAP, which is the breathing mask, is the gold standard of treatment for obstructive sleep apnea. The truth is, technically, it's the gold standard for collapsing airway obstruction, particularly of the pharynx, because using the mask can help blow air in and basically acts as a pneumatic splint with the pressure holding the throat open. CPAP is actually detrimental if it's epiglottic collapse, because it will actually push the air onto the epiglottis and force it over the airway. And it's also not appropriate for nasal valve collapse for the same reason, is that the outside pressure will actually squash the nose in and cause that to block. So CPAP is appropriate for collapsing airway obstruction in the mainstay. It's less appropriate for obstructive elements because to overcome those obstructions, you have to put the pressures up higher. So by putting the pressures up higher, you are then making the use of CPAP actually less tolerable. And as a consequence of that, a lot of people actually give up on it. And it's often quoted that around about 30 to 40% of people stick with CPAP over sort of the 12 months from when it's first started, which means 60 to 70% of people are falling off the bandwagon pretty quickly. So that's that point of view. So that's where other treatments come into play. So, for example, the role of a dentist with a jaw splint is to hold the lower jaw forwards. And whilst a lot of people think that pulls the tongue off the back of the throat, that's actually not in the mainstay what it does. What it does is it lessens the collapse of the lower pharynx. So in that way, it's similar to what CPAP can achieve in terms of its outcome in terms of the anatomical improvement of the airway by holding the throat open. But for both CPAP and also for the splints, you need to have a functioning nose. And if the nose doesn't work, then you're setting yourself up for failure. And that's where the ENT surgeon comes into play. The job of the ENT surgeon is to look at the obstructive elements. And by that I mean the blocked nose, or the big tongue, or the big tonsils, the swelling on the back of the tongue, the lingual tonsils, or the epiglottis that is also collapsing in, and also the nasal valve, the nasal collapse. So surgery manages the anatomical obstructions and 2 of the 3 elements of collapse with regards to the epiglottis and the nose side of things. So from that point of view, the role or job of surgery is not to cure obstructive sleep apnea, it's to lessen the obstructive element and then help any treatments that help with the collapse to come into play. And that's the other 4th arm of treatment with regards to managing collapse, and that is with what's called myofunctional therapy. And myofunctional therapy is exercises for the throat that help with the muscle tone, posture, and breathing patterns. And myofunctional therapy has no role in elements where there is obstruction. It has every role when there is collapse. And again, it's me being pedantic in terms of understanding things, because if you're trying to do exercises on a broken leg, it's not going to work. If you're trying to do exercises on a blocked nose, the effect is limited by that blocked nose. So the role of myofunctional therapy in terms of exercises is to get elements working that are able to improve through the process of doing exercises. Exercises will not unblock a nose. So that's the role of myofunctional therapy. And then we have other things such as looking at body position. Medications sometimes have a role. If someone has nasal allergies, then we may be able to avoid nasal surgery because we can use nasal medications to unblock the nose. If someone has reflux, that can cause swelling at the back of the nose, the adenoids. It can cause the tonsils to swell up. It can cause swelling on the back of the tongue. And as a consequence of all of those things, it then, if we treat it, that swelling can go away and that can improve the airway as well. So when it comes to adults, in terms of the types of surgery that I do personally, so I do a lot of unblocking of noses, a lot of taking out of tonsils, and a lot of what's called tongue volume reduction surgery, which is making the tongue smaller. So just opening up those spaces, getting things working better. I do very, very little in the way of palate surgery because a lot of it is just unnecessary. And then I get other surgeons involved for things such as oral and maxillofacial surgeons when it comes to dealing with skeletal problems. So if there's a problem with the lower jaw being short or the upper jaw being short, that limits the space inside for breathing, and there's surgical procedures that they can do. And the other important element of surgery is to deal with people that are significantly overweight. If someone is significantly overweight and the normal sort of lifestyle modifications and so forth are unhelpful or not productive, then the use of bariatric surgery is really an important element of weight management. So that's another area of surgery that we can get into. And then there's some really exciting and promising techniques where we're looking at things such as nerve stimulation therapy and so forth, where people are just sort of feeling their way around, just trying to find out how that fits into the algorithm of everything that is involved. So I thought I'd just give you an overview of adult obstructive sleep apnea and just explanation of how I approach it. So when someone comes in, we like to do a clinical exam. We look inside the mouth, obviously, look inside the nose, use a nasal telescope to look through the nose down into the lower part of the throat. And part of what I'm looking for is a tumour. I've found a couple of tumours causing obstructive sleep apnea. So it's, and I know pretty much every other ENT surgeon has a similar experience of at least one case, if not more. So that's certainly an important thing to be aware of and something that we cannot afford to miss when someone is presenting with trouble with breathing. And there's obviously other things that we look for. Sometimes you can have hormone problems like low thyroid hormone can cause obstructive sleep apnea. And there can be other reasons that people are tired, anemia, low iron, those sorts of things. So we take a broad approach to the situation. And as I said, the role of surgery is not to effect a cure. It's to reduce the obstructive elements and also to mitigate any collapse of the nose, collapse of the epiglottis, to then facilitate other appropriate treatments, such as CPAP, such as a mandibular advancement splint. Because both of those treatments work very well, but they work better in the patient that is functionally optimized for breathing. So I hope that helps, and if anyone out there has problems with obstructive sleep apnea, I would strongly recommend that you are seen by an ear, nose and throat surgeon that specialises in the area. Have the airway assessed so that you can work out why you have got the condition. The sleep study measurements will quantify how bad you are, but they won't clarify with a why. And I think it's important that any diagnosis is done on the basis of a history and a clinical examination, and then the investigation is then put into the context of those findings, and then management can be guided by all those elements combined. That's the standard approach for any other medical condition that we deal with, and I find it very unusual that we would prescribe a lifelong treatment, that being CPAP, without a clinical examination of the actual area that is compromised from the breathing point of view in the first place. Thanks.